Hereby, I open this academic ceremony in which Ananya Choudhury will defend the academic thesis, Building Federated Bridges, Data Silence Connected by Global Fairways. May I invite you to present a summary of your study and the conclusions of your thesis.
Good morning, everyone. Pro-Rector, highly esteemed opponents, my supervisors, my colleagues, friends, and family. Over the next few minutes, I'm going to talk about my thesis and my research titled Building Federated Bridges, Data Silos Connected by Global Fairways. So there were once few doctors from different hospitals who sat together to solve one of modern medicine's greatest challenge, building personalized care using artificial intelligence. But as they sat together, they realized that they only have part of the puzzle that they need to put together to build that AI. Now, what were the puzzle? First, for building the AI, they needed to share data between each other, but they were not allowed to share data because of ethical, legal, societal, but also technological barriers. Secondly, if they were allowed to share data, they were not able to share data in a meaningful way. This is because data was not interoperable. There were lack of coherent semantics, there was lack of standardization, but there were also too many standards to choose from. Also, they had data of many different types. Data was heterogeneous. There were medical images, clinical reports, clinical notes and prescriptions, genetic data, and also data from wearable health devices. Now, how they solved the puzzle? The first puzzle is that we cannot share data. So, can we keep data at the source and we protect privacy of the data at the source? Maybe yes, we can use federated learning for that purpose. But how do we do federated learning in a real-world setup? And here comes the personal health train, which says, if you don't bring data to the research question, then bring the research question to the data. The personal health train consists of tracks, which are communication channels, station, which contains data in secured manner, and train, which are containerized codes that travel to the station via tracks. But the personal health train also provides us governance and the philosophy of the data. Underlying data is, it needs to be findable, accessible, interoperable, and reusable. So again, solving the first puzzle, data interoperability. How do we solve that? So there are many ways which data can be made findable, accessible, interoperable, and reusable. One of the ways is to represent data in the form of graph data and embed meanings in the form of ontology. So we built a tool which converts traditional relational databases into one of the graph data format called resource description framework, and thus that data is understandable by all the different hospitals and doctors. Having said that, does federated learning work in real world and on heterogeneous data? The next few studies shows the feasibility of federated learning in real world clinical setups. Our first study focused on federated statistics on HL7 FHIR data. HL7 FHIR is one of the widely used standards in the clinics by which clinicians exchange data between different hospitals. So we tried to find cohort statistics of diabetes patients by setting up 2 mock stations, and we could successfully build a federated query and bring the statistics from 2 mock stations containing FHIR data. So federated data analysis actually works, but this is still a mock setup. So for our next study, we tried to find colorectal care quality indicator. And for this, we converted the data into RDF format that is FAIR. And we tried to find what percentage of rectal cancer patients had a complication after surgery. And we compared our process to the existing process, which takes roughly 18 months. In a federated setup and using FAIR data, it took only seconds for a clinician to find the care quality indicator, otherwise which takes a long process, thus showing that federated learning can speed up processes at hospitals. However, our findings were not just technical. We found that data extraction is very difficult from the hospitals. There are privacy assessments which are time-consuming. There is limited understanding of technology among many different stakeholders. The clinical records or the patient records are also poorly structured, and there is extensive IT screening for the tools that are used for federated learning. Also, sometimes the algorithms that are used for finding these statistics are secret by many different agencies and organizations. One of the more important areas of federated learning application is in the case of rare cancer. For example, anal cancer patients, which contains only 0.5% of all cancer cases in the world. So we try to find if we can predict survival of anal cancer patients after getting treated with radiotherapy. We connected 3 different hospitals from Oslo, Maastricht, and Leeds, and we trained a Cox regression algorithm on 281 patients on the following variables: age, sex, tumor size, cancer stage, and radiation dose. We found that our model could learn well from these data and could predict survival with a concordance index of 0.72, which is closer to a perfect prediction. We also found that our model can successfully validate these results at each of the centers as represented by the graph in the right. You can also see a distinction between the different graphs or which represent different centers. This is because there is demographic differences of the populations at each of the center. However, one of the more challenging part of federated learning comes when we need to train on unstructured data like medical images and using more advanced algorithm like deep learning. Our final chapter and final study focused on training a federated deep learning algorithm for segmenting tumor from CT images of lung cancer patients. As you can see in this image, that an AI can segment a tumor similarly as a human does. So we connected 12 hospitals from 8 different countries and 4 different continents, and we connected more than 2,000 patients. And we trained a convolutional neural network, which is a type of deep neural network, and we could successfully train this network. However, our findings shows that it is complicated to train deep neural network in a federated setup, but we could do it in a resource-constrained manner. That means that we could do it using 1 GPU at each center and using entirely open-source software stack. It took us 40 minutes average time per iteration. It was still dependent on the slowest node. But it took us 6 days for completing 64 iterations, showing that how time-consuming and complicated such a process could be. The 2 graphs shows that with each increasing iteration, our model is learning better and better. The right graph shows that our model is making less mistakes over the time. So what we can conclude from all these studies? We can conclude that federated learning is feasible in real-world settings and on heterogeneous data. Federated learning still relies on the core principles of traditional data analysis. Fair aligned standardized data enables advanced federated learning. Fair data and federated learning demands not only technical solutions, but good governance, cultural alignment, and most importantly, the willingness to collaborate. However, there is a lot of work need to be done in the case of making federated learning a reality. We need to work on enhancing the communication efficiency, advanced encryption for both the data and the model. And we need to connect more data sets to improve accuracy of these models trained. We need to address bias and fairness in models. And we need to do large-scale clinical validation for finding the applicability of these models in a real clinical setup. And we need to promote collaborative research over competitive research. Thank you. And I give the word back to Prorector.
Thank you very much for this clear presentation. The opposition will be now opened by Professor Bates, the chair of the assessment committee. He's professor of surgical oncology at Maastricht University.
Well, dear candidates, thank you for your presentation and your work. First of all, I would like to congratulate you and your team with this step forward. I am a clinician, so I'm not a technician, so I'm especially happy to see the chapters later on in your book that show where it can be applied. And I know we have a massive amount of data that are not being used, and this will help in using it and improving our clinical care. I have a couple of questions for you. The first one is an easy one. So, personal health train. With the word personal, I think of an individual, a patient, but you mean it broader. So what do you mean with personal?
Highly esteemed opponent, thank you for your question. So, as I started my presentation mentioning that the doctors wanted to build personalized care, and we are stuck with the issues of data sharing, legal and ethical barriers for data sharing, which is paving the way for building personalized healthcare. So personal health train is a way to bring that personal care and personalized medicine, making it a reality. So one aspect you can see personal health train is it will help us get closer to personalized medicine. The other way is that, which is kind of a future walk of how we are doing it, is that each patient would have control how they want to share their data, giving access to instances of algorithms or analysis which they can allow on their data. So it can be seen in two different ways. That's where the personal thing comes.
Okay. Well, thank you. I might touch on the second part again, but first I would like to ask one of your helpers, the Paraninfant, to read proposition number 1.
The current legal interpretations of GDPR often hinder cross-border health research, slowing scientific progress rather than protecting it.
So Richard Branson, a successful businessman, he said, "My key to success is to find what irritates me and then fix it." So this proposition, I sense some irritation from your part. So what was the biggest thing that irritated you, and how would you solve it?
So as I mentioned, that doing federated learning is technically not a very difficult thing. We can put the right tools at right places. We have high-speed internet. So once we have the right pieces of the tools, we can just stitch together and we can have federated learning. However, the biggest challenges came from the cultural differences, that people are not aware of federated learning. Then people are not aware how they can share data in a privacy-preserving manner.
And which people do you mean?
So it's different stakeholders, but mainly from the hospital side, like the policy officers, the ethics board, but also the clinicians who were not very able to foresee that how much control they are losing by letting this data shared using infrastructure that someone else is hosting somewhere, maybe Netherlands. The clinicians at Oslo or Leeds were not very convinced that, okay, will my data be totally private? Am I giving too much control to someone else sitting over Maastricht?
Did you notice there was a difference between healthcare systems, or was there also a difference within one healthcare system in the Netherlands, that you had some hospitals were easy and some hospitals were difficult?
Definitely. So it's convincing the people in the background. So if the person was more aware about technology and the risks associated with using certain technologies, that person was more easy to convince, whereas someone else had a different opinion and a different viewpoint. So it involved a lot of balancing differences of understanding, opinions, cultures, etc. And those were more challenging than actually doing the technical bit.
And how are you going to fix this?
So it is actually one of the challenges that is an issue with bringing any technology into practice, right? So, sorry. So what we do is we need to create that awareness. We need to educate people. We need to maybe conduct workshops, doing demonstrations, how it is actually done.
So these people in the hospitals, I would say they're all intelligent, they're not ignorant, yeah. They should know. So they already know the advantages. Are they afraid of something?
Understanding the privacy risk.
Yeah, you told losing control is one aspect.
Yeah. Then risk associated with privacy, that whether indeed federated learning is it just in saying that it is protecting privacy or it is actually also protecting privacy. So giving live demonstrations, those help them understand. But also thesis like this will eventually help them understand things better.
So you are aware that there's been a data leak in the last half year of the screening and cervical cancer in the Netherlands. So the data of hundreds and thousands of people were stolen and out in the open. So I understand that keeping the data in the hospital itself is safer.
Yeah.
But can you tell them it's 100% safe? So is there still a risk of data leak with the health train?
This takes me back to my early days when I started learning computer, and one of my teachers says, while teaching computer security, that the only way to keep your computer secured is unplug it and put it in the shelf. So there's always some risk, but as long as there is risk, we will find ways to protect the data. So this is keeping data at the source is only one step of protecting privacy. We need to have advanced encryptions. We need to have human in the loop and audit trails to keep checking that indeed the algorithms and the infrastructures are doing what they are supposed to do.
Yeah, because when I see a train running, I like the image of the train.
Yeah.
So the train comes in the hospital,
yeah.
But could be a spy or a criminal on board of the train. You can import something because there's an interaction with the data. So there's always a risk there, isn't there?
Yeah, definitely. So the trains that actually reach the hospital has full authority to say no to the train. Also, before sending the train, there is an agreement among all the parties, what the code contains, what the code does, what it extracts from the data and sends back. And the consortium of different hospitals and the persons can approve or disapprove the train. So it is not that a researcher sitting over here is blindly sending a train and the clinicians have no idea what they are receiving. So they are always informed, their consent is taken. So we try to...
Okay, you have convinced me you have thought about this, this issue. So I have another item I would like to address. So the studies you show as examples, so there's a lot of data already there, so you can do large real-world comparisons. It's all retrospective, but we also do prospective studies a lot.
Yeah.
Do you think this could also be used, this data train, in prospective studies, even in randomized studies?
Yes, definitely. So one of the studies we will do in the future is actually more about prospective study, like simulating a randomized controlled trial, clinical trial. Although I haven't done it, but I believe it can be done. Yes.
So you know the way it works now, that's still data warehousing. We have two big companies. So that's Redcap and Castor. Are you aware of those? So they are used for clinical trials, but you put all your data to them. So you give it to them. So if you solve all these hurdles, you think in 10 years they will be out of a job?
I don't think so. Anyone would be out of the job, because even to tell AI how to do things, we need human in the loop. And that's also one of the findings of my thesis, is that people and collaborations are important. You cannot take them out of the whole equation.
Yeah, I think these people will automatically retrain themselves, and they become a part of the other way too.
Yeah.
I'm happy with your answers, and I'm giving the word back to the prorector.
Thank you.
Thank you very much, Professor Bates. The opposition will be continued by Professor Het Hoen, Professor of Bioinformatics at Radboud University Medical Center in Nijmegen.
Yes, I'm on this side. Congratulations, dear candidate, on the completion of your thesis. It was a pleasure to read, and also I'd like to thank you for making still some small changes after the draft manuscript was submitted. It's really a great pleasure for me to participate in this Corona Today. I think it was back in 2016 that your promoter, Professor Dekker, and Professor Mons and myself sat down somewhere on the ground floor of the LUMC research building and launched the concept of personal health train. And I think that was even before beers arrived, so that was quite an accomplishment. You're one of these people who made a real thing out of this theoretical concept, and I'd like to congratulate you on that. Very well done. Before I start discussing some more around the future of personal health train, I would like to ask you a few methodological questions concerning both chapter 7 and 8. What I seem to be missing here is a comparison with the results obtained if one would have a complete data set on the centralized location. I think theoretically there should not be a difference in the analysis, but you have not empirically proven this. Why not? And what is the expected result there?
Highly esteemed opponent, thank you for your question. So if I understand, you are pointing more towards like if the models trained in federated setup is comparable with a model trained in a centralized setup, right? Yeah. So if you see if in chapter 7, if you compare the C indexes obtained from training the federated learning model, which is roughly around 0.72, and we trained the model in many different setups, like we trained it in 2 centers and validated it in a 3rd center, and we made these comparisons. So, and if you compare C index trained in a centralized setup, these are pretty comparable. But also, we did another study, which is not part of this thesis, which did a equivalency test between models trained on centralized setup and federated setup. And we found that if not better, if federated models are not better, but at least it is comparable, let's say. It's not too bad.
But why are you saying it is even better? It should be the same. I would say.
Yeah. It's not exactly same, but it's comparable. But we must also understand why we do federated learning. If we could have collected all the data in the world and stored it in a centralized repository and trained a model, probably we would have got a very nice model. But we cannot do that. So there's always a trade-off that we have to address, that there's no other way of training models other than federated learning in certain cases.
Okay, but why is it then not the same?
So there is, so we train a model in a federated setup, and we train some intermediate models which has captured some bias from the different data sets. Mm-hmm. And when we are aggregating the models, it's a different process than how we are training model on a centralized database or at each center. And those aggregation algorithms might also contribute towards the non-equivalency of the federated models.
Okay. So let's take then a very specific example, the Kaplan-Meier curve that you show in maybe also in your presentation, but also in figure 7.2. I think a Kaplan-Meier curve is not really sensitive data anymore. It's basically just numbers, right?
Yeah.
So what is your issue with producing an aggregated Kaplan-Meier curve?
So for produce an aggregated Kaplan-Meier curve, we still needed some patient-level information, like the linear predictors of each of the patient data at each of the centers, which at the time of the study, the algorithm or the infrastructures were still not able to do it. That was one of the future perspectives that we are addressing in the current research that we are doing, that we could produce an aggregated Kaplan-Meier curve. So for this particular study, back in the time of a couple of years back, we could only produce a Kaplan-Meier curve per center basis.
Okay, but if you then want the overall Kaplan-Meier curve, you just add them up. Or am I thinking too simple?
No, we cannot do that. We need to share some patient-level information for doing that.
Okay, thank you. Well, then a bit more on the philosophical side. So in the PhD manifesto, it actually states that the personal health train should also empower citizens to manage, safeguard, and share their data.
Yep.
The citizen can also act as a data controller as compared to the hospital or the research institute. And this seems to be a bit of an underexposed subject in your thesis, although I know that some of your group members and perhaps even yourself have done work on this. So can you enlighten me on your perspective for putting really the individual citizen in control?
That's a future goal, and that's where Personal Health Train Manifesto also points us, that ultimately it's the patients which should have the full control over their data and what algorithm is being trained on their data. At this point, for testing the feasibility and whether personal health train works or not, I think we only considered like retrospective studies where consent is taken from the patients by the hospitals and not dynamically by the patients. But before going there, we also need to properly, before making that part of the manifesto a reality, we also need to have the right infrastructures given to the patients where they can actively monitor data and give control the data. So we first need to work on that part, then join personal health train on top of it to make it happen.
I'm looking at the pro-rector.
I think you have to stop.
Okay, well then I thank you for your answers and I return the word.
Thank you.
Thank you, Professor Toen. We continue with the next opponent, Professor Cornet, Professor of Medical Informatics at Amsterdam University Medical Center in Amsterdam.
Thank you very much. Dear candidates, first of all, congratulations on the completion of this thesis, which I read with interest. And I'm glad to have the opportunity to discuss with you its contents. You also, in your introduction, you mentioned the importance, or actually the finding, that there is currently a lack of coherent semantics. So what would be your contribution to overcome this lack of coherent semantics?
So we propose two things in the thesis. That first thing, that data needs to be findable, accessible, highly esteemed opponent. Thank you for your question. So we propose that data needs to be findable, accessible, interoperable, and reusable. But also we mentioned that there is not one way to make data interoperable, right? If we see on the clinical side, like standards like DICOM, HL7, and many other standards are used for day-to-day data exchange between clinics. If we see on the research side and secondary usage of data, standards like RDF representation, then OMOP are more widely used. But for doing federated learning, we just need data to be semantically interoperable and at least follow some standard.
Yes, I would like to pick up on that. So I agree with you that semantics are very important.
Yeah.
So I read the title of your thesis about data silos connected by global fairways. And then I was reading your thesis, trying to discover the semantics of fairways. And ultimately, I had to resort to Control F. I found gateways, pathways, railways, even Norway. But I didn't find fairways. So can you please provide me with the semantics of fairways?
So the underlying, one of the prerequisites for doing federated learning is having data fair.
Fully agree.
Yeah. So without, if we are considering one study and each of the centers having many different ways of representing data, the algorithm won't be able to understand the data. So whenever we are doing federated learning using personal health train, the tracks has to be automatically fair, or else the trains won't be able to travel and bring meaningful information from the stations.
So does that mean that fairways are like fair railways in the personal health train infrastructure?
Can you please repeat your question?
So, well, my question still is, what are fairways? Can you provide me with a definition of fairways?
So fairways are the connections that are built between a geographically remote data set at a different hospital and a researcher like me who's sitting in Maastricht. So if I need to learn from data, the data needs to be fair at that hospital. So that kind of automatically makes the communication channel that the data is brought back to me fair as well.
Okay, then for now I will stick to my definition of fairways being the fair railways in a personal health train infrastructure. And then you talk about semantics and you talk about the many standards that exist. And in your thesis, you explore various standards. Two important ones are RDF and HL7 FIRE. It seems that in your thesis you go back and forth between RDF and HL7 FIRE. If you could pick, what would you do? Would you use one, the other, both? Can you elaborate on that?
So, no, I wouldn't pick one. And that's what I also want to convey in my thesis, that you need not pick one. You can pick one standard and you can still do federated learning. So if you do it using HL7 FIRE or RDF or OMOP, as long as you have your semantics in place and understandable, it doesn't really matter what standard you are picking. But it is important to have the data standardized.
Yeah, but then don't you get the problem that if you, and in your presentation earlier, you said you go from 18 months to seconds. Well, if I want to collaborate globally, and I think you did a nice job with your European demonstration with Leeds and Norway. So if I would like to do that, and one group is working with HL7 FIRE, another group is using OMOP, a third group is using CDISC, a fourth group has implemented OpenAir. I need to do a lot of well, and even if I know all of these models, I would need things like transformations, maybe mappings across the standards being used, because OMOP has its own vocabulary, etc. So I doubt whether then it would turn into seconds, or where I would need a lot of preparation to be able to, well, get my train loaded with the correct algorithms.
That's a very important perspective, actually. So the 18 months we mentioned, the process takes when a clinician uploads the patient records to the National Registry. From that point till the point the employee at the Quality Audit Office calculates and sends back, that time is 18 months. However, in our process, indeed it takes some time to create the mappings, to extract the data. But once we have the data and we have the mapping, the transformation is done automatically, and that doesn't take much time. And once we have the data in the FAIR station, then doing a statistical analysis on that data using personal health train, that itself takes only seconds. But indeed, it has been one of our observation that before we perform federated learning, extracting data and mapping the data and converting data into FAIR format does take some time. And usually that time is more than actually doing the analysis.
Yeah, did you say FAIR format?
Yeah.
Yeah, so I would say there is no FAIR format.
No.
There can be many FAIR formats. And you mentioned transformation.
Yeah.
So that does mean that you still pick some representation, and you don't make one station using OMOP, to which I would talk using OMOP models, one station to which I would send a train using HL7 Fire. So apparently you do transformation to harmonize whatever in the stations.
We can do, even if one station is having OMOP and another one is having Fire and another one is having RDF, we can frame a query in our algorithm in a way that it can query from all the stations, like all the different data formats across the different stations. However, it is advisable to use the same semantics. The structural representation can be different. It can be OMOP, it can be Fire, it can be RDF, but the semantics needs to be same. Like if I'm representing lung cancer using a term in SNOMAD city, then I would expect all the centers to represent using the same terminology.
Yeah. That would be a topic I would like to dig into, but I have one other question I'd like to bring up, which relates to this this topic, because you give the example of doing in chapter 5 the body mass index application, sending that to a station using HL7 Fire. Can you talk me through that? Because I know the Fire requests, maybe not in depth, but I know the resources that exist. So what resource would you use to get body mass indexes out of a system, even if the system maybe only has length and weight, and you would have to do the BMI calculations through this application? How would you send an application using HL7 Fire?
So HL7 Fire provides us ways to structure data, add semantics to it, but it also provides us mechanism to query the data. And how HL7 standardized data all over the world is the work group creates profiles, which are like templates for structuring data for a particular region, or nationwide, or the worldwide. So there are certain profiles which are accepted worldwide. For this study, we took only the very widely accepted HL7 Fire profiles, like the patient profile, then the patient demographics, and if I remember it correctly, there is also another BMI profile or something like that. But it can be structured a bit different way.
I'm actually afraid there will be many BMI profiles around the world, because these days everyone likes to create their own profile. Like with, it's the saying, and then I conclude, standards are like toothbrushes. Everyone wants to use them, no one wants to share. So, well, thank you for your answers. I'm happy with them, and I return the word to the prorector.
Thank you, Professor Cornet. The opposition will be continued by Dr. Urovi, Associate Professor of Data Science at Maastricht University.
Dear candidate, thank you for giving me the opportunity to read your thesis, and congratulations for your work. I would like to pick up a little bit on what Professor Cornet was mentioning. So, the first step in the platform is the data verification, including standardization. I would like you to describe the difficulties in this step. It seems to be a very manual process. Whether there is opportunities also to automate this part of the process.
Esteemed opponent, thank you for your question. So, indeed, verification is challenging. to do at this point. First challenge is that people are not very aware of what fair data is. So there is a lack of awareness and education. Some people are not believing fair data can help their day-to-day activities and research. So there is a cultural difference of mindsets as well. Also, we don't have very advanced tools to verify data. We have tools here and there and in chunks. As one of my chapters I represent, there is a tool, a way to convert fair data. However, as I mentioned, that fair data is not just RDF. So how we define fair data, in what format we convert fair data, so all those cultural differences are there. And that is also one of the conclusive messages in my thesis, that data verification is not just a technical problem, it's also a cultural problem as well.
Thank you. And would you say there is ways also to automate, therefore?
Yeah, definitely. So ideally, it would be beneficial for the clinicians and the researchers that we have data verified from bottom up, from the EHR straight to the research databases, but we have not reached there yet. I believe over next many years, if we keep promoting fair data, federated learning, and studies like this show clinicians that there is a clear benefit of verification of data, we would have a much more streamlined data verification process.
The second question that I have is about data quality. Of course, when you're building a federated learning, you are not seeing the data. There might be outliers, there might be problems that you don't get to see. Did you have any approach into this, or how would you deal with this problem?
So as I mentioned, that all the processes that we need to take care in a centralized training or centralized machine learning life cycle, we still need to do it in federated machine learning life cycle as well. That means we need to check data quality, whether there are missing values, whether they are outliers. One of the ways that we did in one of the chapters, chapter number 7, is we did exploratory data analysis per center basis, and we collected the results and compared how the populations are different. Sorry. Now we can also do it in a federated manner, that we can send one algorithm in a federated manner to bring this statistical analysis from each of the centers. Sorry.
You can have a drink if you want.
Yeah. And it is important to do this exploratory data analysis to understand patterns of the data before we actually send a machine learning model. Because, just like centralized model, these basic steps are also important in federated learning.
Yeah. The third question is about data privacy. Not in general, but more on the weight component. So if you're sharing models, you are sharing data weights, and there is some research suggesting that there might be privacy leakage.
Yeah.
What is your take on that, or whether you had some processes in place for avoiding any data leakage?
Thank you for the question, and it is actually one of the primary focus of chapter number 8, where we were training our federated deep learning models, and the intermediate models that are trained on each of these centers were susceptible for data leakage, because those can be reverse engineered to create patterns of the data. So we wanted to prohibit the researcher or any third party or external person to have access to these intermediate models. So on top of the original personal health train infrastructure, we introduced a secure aggregation server, taking the aggregation of the models away from the researcher into a secure node or secure place, let's say. Also, we transferred weights instead of gradients. Gradients were more susceptible for data leakage problems, whereas weights has some benefits over it. At least the literature says so. So we tried to prevent extra data leakage by creating these security protocols on top of the original personal health train infrastructure.
The assumption, however, is that the trusted server will have to be trusted by all parties.
Yes. Yeah.
The last question would be about the future of the personal health train. So we live in an era where generative AI has picked up quite a bit. What would you see, or how would you see the future of the personal health train, whether we will have AI agents or anything of this sort involved into the aiding the federation, the federated learning process?
Yes, definitely. So one of the first ways bringing personal health train and generative AI is maybe we can train more foundational models that are useful for healthcare setups, using personal health train and connecting different data sets. We can create these foundational models, but we can also create AI agents. Maybe some agents can also help us build the algorithms and start the process, and I can take a sit back and not do all the technical heavy works. I can just train an agentic AI to do the task for me. So definitely, yes, I can foresee that in the future.
Thank you. I'm happy with the answers.
Thank you very much, Dr. Urovi. Then the opposition will be continued by Dr. Buijsen, radiation oncologist at Maastricht University Maastro Clinic.
Thank you. Dear candidates, I want to start by congratulating you on this beautiful thesis. And of course, I also want to include your supervising team in these congratulations. I have to admit that I was a bit reluctant to accept this invitation by Professor Dekker to be part of the opposition today, because I already got lost when reading the title of your thesis. And maybe that's already a sign that that's a topic we have to work on. Thinking that I could at least learn something from the preparation for today, in the end I decided to accept. And I have to admit that it was a learning experience. For example, I came across some abbreviations that I use in my daily work, like DICOM, HL7, but I never knew what the abbreviations actually meant. So that was new for me. It probably won't surprise you that I would like to discuss with you Chapter 7. I got very enthusiastic when I saw the title, Predicting Outcomes in Anal Cancer. Sounds like a big step forward, while it's a rare cancer, as you already mentioned in your introduction. And it's difficult to do research on this topic. In Maastro, we see between 20 and 25 patients a year, so that's really a very small group. After I read the chapter, I became a bit hopeless and depressed, though. I remember the very nice and fancy animations your supervisors showed us years ago, with a train picking up data at different hospitals and then combining all these data to a super prediction model. But now I saw that you had to do a lot of work. You worked very hard to only build a proof of concept between 3 hospitals. And I read in the article that a code book was provided to every center, so I assumed that they had to do a lot of manual work. And I happened to share an office with one of the co-authors, and I know that she had to put a lot of work to collect the data of Maastro and to prepare them in order to be usable for your work. And then in Chapter 9 you write, this allows the researcher to focus primarily on analysis, potentially reducing their workload and stress. So I was wondering, what is needed in your opinion to really make step forwards in order to use this federated approach on a larger scale?
Esteemed opponent, thank you for your question. My first comment would be, it is more difficult to do anything for the first time. So for creating a proof of concept, it will always be more difficult than when a process is established and in place. So researchers like us would happily do that hard work so that clinicians in the future can have an eased up life. And that's why the thesis is here for that. Yeah, it is possible, it is feasible. Yes, it is challenging to have data in the fair format. It is challenging to convince the hospital people to install the infrastructure, get the privacy assessment done, the IT screening done, but it's probably done only once. So for any future study, when you are doing, you are using all the established processes there.
But that's about the infrastructure, but how to collect the data within an institution, because that's what we, on a daily basis, struggle with enormously. And Maestro is involved since the beginning by Professor Dekker's group to use data science and to learn from our data, but we cannot easily get the data for the analysis. How can we make that better? What is needed for that?
So it's a back and forth process that we as data scientists, we propose that, get your data into findable, accessible, interoperable, and reusable format, with the last pillar of FAIR being reusable. Mm-hmm. So once you have the data findable, accessible, and interoperable, it automatically is reusable. So as the clinicians get used to that process, they understand that it's always beneficial that we get data verified from a very bottom-up approach, that at each step in day-to-day clinical processes, as well, if you have all the data standardized in well-formatted, interoperable form.
Yeah, you mentioned a very important word, standardized, and I think that is not what is daily practice in the clinic nowadays.
Yeah.
Are there methods to improve that, to use of to like force doctors to make their data standardized without making a system that is not working in clinical practice?
So we can use tools like the the tools shown in this thesis. This can help read data from relational databases. So the doctors are filling in certain forms, and the data is being stored in certain relational databases in the background. Now, tools like this can read from those databases automatically and convert data in the FAIR format. But we can also slowly integrate those more in the clinical processes in the coming days without pressurizing the clinician too much, so that he can focus on the actual care given to the patient instead of bothering too much about the data. And we as data scientists and researchers are exactly here to help the clinicians with those processes.
Okay, well, maybe it's good to switch to a topic that is related then. I would like to ask one of the paranyms to read Proposition 9.
Trust in healthcare AI must be earned not only through metrics, but through meaningful, interpretable results.
Yeah, so trust must be earned. I think that's really still a problem, that many clinicians are reluctant to use prediction models as long as they don't really understand what is behind these models, and that is connected, I think, to the underlying data. For example, in chapter 7, the group of clinicians defined some factors that were believed to be important in the distinction between high-risk and low-risk patients. And one of them was N0, so node-negative patients versus node-positive patients. But in anal cancer, that's a clinical evaluation, so it's based on imaging, and there you can have the problem that in different countries, different standard imaging procedures are used. Maybe in the Netherlands they use standard PET-CT, in Norway they do an ultrasound with fine needle aspiration, and in the UK they base it purely on MRI. Still, this N0 versus N plus was an important factor. How can you correct for that? How can you build models in a way that clinicians still know when to use them and how to use them?
That's a very important aspect, actually. So one part of the trust factor is that it is important and clinicians want to understand what the model is actually doing, that it is interpretable, that it is explainable. The problem lies with deep learning-based models, that it is not quite explainable, and hence I think clinicians still prefer using more regression-based models, that it is understandable and explainable. There are ways to make a model, machine learning model, interpretable and explainable. Let's not go there, it's entirely one part of research that people focus, how to make models interpretable and explainable. But the other part, that the differences, let's say in the scanners, or how a GTV is delineated, how it is labeled, and etc., those come from using different scanners, but also the people who's doing the delineations, marking the GTV, marking the TNM staging, etc. This is a problem. Let me address that. Yes, this is indeed a problem, that we don't have a uniform way of doing things. And when it comes to using data from many different geographical locations, nationality, regions, there will be differences in how this data is captured, how this data is labeled, and etc. Now, whether we see that as a challenge of not doing federated learning, or we find ways to mitigate that challenge, maybe we find ways to mitigate that challenge, we find how we can normalize these differences, how we can address these differences in our model. As part of the thesis, we did not delve too much in how we address these differences. Our focus was more on if doing federated learning is feasible in a real-world setup, and we focused that, yes, these are the problems we still need to address.
Yeah, but do you have any ideas how to make progress on that?
If we can make people collaborate at the data annotation phase, maybe using a consensus that many different hospitals use some standardized procedures for annotating data, maybe we can have a more uniform data representation in each of the centers. But I think the problems will still be there, as you cannot make everyone agree to one particular thing. And these differences are not always bad, I would say.
No, of course, they can also help the model to get stronger. But I think, but I'm not a data scientist. I think that if there are differences between three hospitals and.
Thank you very much, Dr. Bouwsen. You can follow up the discussion later on.
Yes.
Sorry to interrupt you. Ananya Choudhury, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room. Ananya Choudhury, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Dekker is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor. Please, all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Then by the authority vested in us by law, and in conformity with the decision of the committee here present, I hereby confer upon you, Ananya Choudhury, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, by the secretary, and by the other members of this committee, and affixed with the official seal of our university.
All right, dear Ananya, or better said, Dr. Choudhury. Sounds good, right?
Thank you, yes.
Yeah? Okay. First, I want to congratulate you, of course, on this doctoral degree. This is something to be proud of, and I'm sure you are. And we are, for sure, also proud of it. It has been a long journey, right? With many ups and downs, and maybe some different circumstances in work environments, let's say. You could almost say it's the story of Ananya in Wonderland, right? Going down the rabbit hole, as what I heard also from others, your mind can sometimes get into different places. I even was told aerodynamics, yes. But always coming back on track, what needs to be done, right? However, you have shown yourself to be capable of working through all these situations as a true digital nomad. Because the story starts actually going down the rabbit hole around August 2017 already, right? Then you indicated that you were interested in a PhD position on rectal cancer prediction models in Maastricht. And at the time you were working and collaborating already with Andre and Len on the Bionic project, right? From CDAC in India. Well, after interview procedure, making necessary visa and travel arrangements, which also took time and some work, you joined us in Maastricht in June 2018. And well, next to this project, you quickly started to take on additional projects, right? To apply federated learning here in the region in a project called Limburg Mate or Lyme, which gave us a very open book in terms of what do we want to do in this research project, which looks great, but was directly also a challenge to get everyone involved to get something actually done, right? So we opted to focus more on the technical groundwork to make federated learning possible, fair data, which also shows in the thesis, and at the same time to see if we could implement these ideas. And of course, both at that time were both seeing how does a PhD work, you as a PhD student, and for me as a supervisor, to be honest, right? So afterwards you indicate to be linked to more clinical projects and to stay on rather than to stay only on a technical part. And here Len came in, which added you to AtomCAT, the Christmas Challenge, Argus projects, or better said, multiple rabbit holes again, right? You were included in several ad hoc projects, for example, with Sao Paulo, MD Anderson in Houston, Texas. And the latter was interesting because you were ready to go to MD Anderson and went, but MD Anderson was not ready for you yet, right? So, however, after a true digital nomad period in the United States, you managed to get the project going and come back with actual results, right? In all these projects, main or ad hoc, your perseverance and technical skills were brought into the real world situations, which means as a true engineer, getting nodes online at the same time, performing learning runs, debugging GPU issues in federated learning infrastructures. Well, you have seen all the possible things that can go wrong, but you stayed always calm, at least on the outside, as we can judge, and got it back on track. Which also means in the office that people sometimes were wondering what you were doing. Coming in at 11, going for lunch at 12, leaving again around 2 o'clock. But given that you had to align centers in Asia, Europe, North and South America, it also means that your projects didn't have a 9-to-5 schedule, let's say. On a personal note, this PhD also hasn't been an easy journey for you either. Like many students, there was of course a COVID pandemic, but also personal level things were not easy. Having your partner in the United States, your family back in India, made that you were living a true digital nomad life, traveling the world in good and bad circumstances. Therefore, I'm good to see that your family is here, and of course also that your father is watching as well. However, looking back at these thesis chapters, you have shown to deliver actual clinical insights based on some technical concepts and real-world data using a challenging technical environment. The actual pieces of the puzzle you also described in your presentation today. This work hasn't gone unnoticed as several projects are coming back. AtomCAD 2, Argus 2 now being set up, and of course the other list of projects that we're doing where you're all involved in. So that means that Andre, Len and myself are happy that you're staying as a valuable team member to get this research group going. So not only for getting the clinical insights there, but also to improve the methods how we do these federated learning things. So in the end, this Ananya in Wonderland story did not end as being merely a dream, right? This thesis and the certificate is actually here in front of you. And I think you can look back on a very interesting PhD journey. And I'm sure more journeys will follow. Thank you.
Dear Dr. Choudhury, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. Of course, I also congratulate your family, friends, colleagues who, one way or the other, have contributed to this PhD journey, which has come to an end today. I'd also like to congratulate your supervisors, and I'd like to thank all the members of the degree committee for the time invested in being here, preparing for this meeting, and especially our guests from outside Maastricht, Professor Cornet and Professor Hoon. Thank you for being here. It's very much appreciated by the university. I must say I personally enjoyed your defense. You were able to talk about it in terms that also for a person like me, who's not really involved in this area, it was quite understandable what you've done. You looked confident. I hope you were confident. And I really enjoyed seeing your enthusiasm in going into discussions with the members of the degree committee. Hopefully you also will look back with satisfaction on this PhD defense, but it's now time to forget everything, enjoy, and have a nice day. And with this, I close this academic ceremony.
Please all rise.